You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Dunn, welcome to the Nailed It Ortho Podcast. So happy to have you on.
Yeah, thanks for having me. It's going to be fun.
Yeah, I'm looking forward to. We haven't had a lot of hand topics. We've had maybe a couple of episodes, but I'm looking forward to this topic in particular because I think we're talking a little bit before off air. I've seen a couple of these, and I've seen some of these be missed before. So hopefully we can stop people from missing these and get some education out there.
All right, sounds good.
So we typically just start off a couple of questions to get to know you a little bit better. And so what kind of brought you into the field of hand or upper extremity? What kind of brought you that way?
Well, I was always interested in orthopedics because I played college sports. I played lacrosse at Colgate, and I think I was always interested in athletic injuries just from playing sports growing up. And during medical school, I think I gravitated towards orthopedics for that reason. But once I got into residency, I saw primarily hand injuries in the ER, and hand injuries do make up the predominance of orthopedic injuries through the emergency department. And I trained in El Paso, and we were the only level 1 trauma center for hundreds of miles, really, between Tucson and Dallas. And so a lot of these injuries, smaller injuries, we couldn't take to the OR. So we treated a lot of these injuries in the emergency department. And I thought I had the most latitude with my hand faculty and particularly Dr. Cruz. And who's recently moved back to El Paso, but he was my chairman at Texas Tech for a long time, and so I fostered more of an interest in hand surgery than I did sports and shoulder and elbow, which is what I had initially thought I was going to go into. So I think just those long nights in the emergency departments at Texas Tech, I think that's what brought me to hand surgery.
Yeah, I always had a good time, at least managing the hand fractures. The hand pus, not as much, but the hand fractures and the other consoles, I always thought those were pretty interesting, and how, people could get better.
Unfortunately, there's no escape from hand infections, and that's there's good and bad with every subspecialty, but in hand surgery, it's definitely infections, and stiffness is an unfortunate part of the practice.
Yeah, I know it's rough, or can be rough. And another one of the things that, you're in the military, you're in the Army. What brought you towards that? And I guess how is that experience being a surgeon, also kind of in the military? Because we have a lot of people, we have a lot of residents that listen to this. We also have medical students that are going into orthopedics that will, that are considering joining the military at some point as well.
Well, September 11th happened when I was a sophomore in high school. I remember it like it was yesterday. And I think that during high school, I had an interest in attending West Point, and I actually applied and was accepted to West Point, but mostly for athletic reasons, went to a different school, although we ended up playing West Point twice a year. But I've always had an interest, I think, in the military, and actually in college, we would play West Point at West Point, and I thought it was really cool. And the scholarship for medical school was good. My loan, the rate on my loans was going to be high, and so I thought I would join the military, and I think that's afforded me good training. The fellowship, the military has 2 orthopedic fellowships. One's at West Point and one is at Walter Reed. The Walter Reed fellowship, that's a hand surgery fellowship, is partnered with the Curtis National Hand Center in Baltimore, which is renowned. And actually, the military fellowship was started by Raymond Curtis, who's one of the fathers of hand surgery. And so it's a very historic fellowship, and it's something I'm very proud of. And I think I received excellent training. So I think there are still excellent training opportunities for medical students and residents through the military. Most frequently partnering with civilian institutions at nearby installations, but I think in general I've had good training, and certain experiences I've had I probably wouldn't have had otherwise. So I am grateful for that.
Yeah, that's awesome. That's great. I'm glad you enjoyed it and are able to share and talk about that experience. And so now we'll transition a little bit and talk a little bit more about perilunate injuries. And let's just, I guess, take it all the way to ground zero. I guess, what is like a perilunate dislocation, and how does this occur? When does this happen?
Well, I think a couple main mechanisms of injury are skateboards. I don't know why that is. In where we are here in El Paso, it's falls off the border walls is common, and then roofers get these when they fall off the roof or fall off the ladder, something like that. So those are probably the three most common patient cohorts where I see this injury. And instead of failing to the distal radius, which is probably more common, a distal radius fracture, there's a ligamentous, which would be a lesser arc, or a greater arc injury, which is a perilunate with wrist fractures associated, radial styloid, or sometimes the energy is expressed through the scaphoid. You can have a transscaphoid perilunate fracture dislocation. But probably for the sake of this talk, the most common thing residents may see would be a failure through the scapholunate ligament, and a complete failure. So that would include the three portions of the scapholunate ligament, the dorsal being the stoutest, and kind of what happens is the scaphoid extends to the point where the scapholunate ligament ruptures, and as the scaphoid extends, the space of Poirier is opened, and the lunate's position within the carpus is kind of maintained by the short radial lunate ligament, and then the rest of the carpus typically dislocates dorsally. So the capitate will end up sitting on the distal radius where the lunate should be, and the lunate is palmar, and that's why a lot of these are associated with carpal tunnel syndrome. In the literature, it's reported between 7 and 25% of the time. I think 25% of the time is typically what I would see. And actually, we did a military study probably about 6 or 7 years ago now, and that's what we found, is that 25% of patients have acute carpal tunnel. But the interesting thing is if you reduce them, it pretty much goes away. Sometimes not right away, but if you can get this thing reduced, I certainly would be less concerned about acute carpal tunnel syndrome. But again, that acute carpal tunnel is coming primarily from that lunate sitting palmarly.
Yeah, and you actually just touched on a bunch of test questions that you just said, and I know this because I was doing a lot for my boards. But one of the things that's just to reiterate that you mentioned, you're talking about the dorsal scapholunate ligaments being the strongest, how the scaphoid extends, and after it goes through this arc of injury, you have the short radial lunate ligaments that are the last ones to fail, and this is kind of that Mayfield classification, right? That's kind of what we're referring to a little bit as far as the mechanism of the injury or how it occurs.
Yeah, I think for resident, the Mayfield article I think was in 1980s, so a while ago, and I think like with many orthopedic classifications, it's not incredibly helpful, and it's definitely not prognostic or diagnostic or anything. I think it's suggestive. It's suggestive of the kind of direction of some of the energy, but for the most part, I don't think I can't imagine they would test you on the Mayfield classification. But it is good to know that as the lunate extends and the space of Poirier opens, the short radial lunate maintains the position of the lunate. And I think if you ever have a test question and there's an arthroscopic image of a wrist, the answer is probably a short radial lunate. It's the stout ulnermost ligament on the lunate, and this ligament really does not fail. So that'll maintain the lunate in its position in the carpus.
And can you quickly touch base on what that space of Poirier is?
So the space of Poirier is a potential space, and it's right under the ulnocapitate ligament. And as the lunate extends, this potential space widens, and it's just kind of just a potential a potential space where the lunate can kind of slip out palmarly, and that could potentially, I suppose, be tested as well. But I think most of the questions will revolve around the short radial lunate.
Yeah, and so can you you mentioned this a little bit earlier, but I guess these different stages of perilunate instability. Can you kind of just take us through what those are and kind of what these different, I guess the position of the lunate can change a little bit as well. Can you kind of just take us through these?
Sure. So the first thing that will occur is the scaphoid extends, and the SL ligament sequentially ruptures palmar to dorsal. And once the dorsal ligament is ruptured, that the wrist really becomes unstable, and so that would be the initial path. Subsequently, Well, and then again, the short radiolunate maintains its position. Subsequently, the upper limb of the arcuate ligament may pull the triquetrum dorsally, and that can cause an LT dissociation. I think that's pretty rare, and I think certainly less clinically impactful compared to a scapholunate ligament injury.
Right.
And then finally, the capitate can be forced into the forced by the radioscaphal capitate ligament, which I can touch on here in a sec.
Yeah, sure.
And this slips the capitate into the kind of the proximal row. Now the RSC is important. You usually are often tested on that because if that ligament is cut in a proximal carpectomy, you'll have ulno carpal translocation. So the whole carpus kind of shifts ulnarly. And actually, if you do a PRC, the RSC ligament it's kind of an oblique band palmarly, and it almost feels like a guitar string. It's pretty stout. And so that RSC is kind of what's dragging the capitate into the kind of the lunate fossa where the lunate would normally sit.
Okay. Yeah. And I definitely saw that as a test question. They're just like you just said, they're talking about doing a proximal row carpectomy. And then if you cut, the radioscaphal capitate ligament, that you get ulnar translocation of the wrist. I've also seen where they show you just an x-ray where you have ulnar translocation of the wrist, and they're asking you, well, what ligament was injured? So,
right. I've seen a limited case series where they've tried to repair that and they just don't do that well. So I had a case where another surgeon did a PRC, and the patient, a couple of years later, the patient comes back and a significant wrist pain. A PRC is a proximal carpectomy, typically reserved for arthritis. It's a good option if someone wants to maintain motion. And I think initially it was described for older patients, but really there's been pretty reasonable data. Patients under 35 getting these and do fine. I like a PRC over a four-corner fusion, but anyway, a PRC where maybe the palmar dissection is a little bit aggressive. The radioscaphal capitate ligament's cut, and as you say, the carpus shifts ulnarly. In that setting, if that happens, the best option is probably a wrist fusion at that point. I think repairing that ligament is extraordinarily difficult, especially after the fact. But the RSC, to bring it back to perilunates, is important in part of the pathoanatomy of a perilunate, as it maintains the capitate in the lunate, where the lunate should go, which is the lunate facet of the distal radius.
Yeah. And then earlier you mentioned kind of a greater arc injury. You mentioned like a transscaphoid, perilunate, fracture dislocation. I know there's a couple different nomenclatures, and there are greater arc injuries, lesser arc injuries. Can you kind of just go through like what are these? Like what does it mean by greater arc injury or lesser arc injury?
So a lesser arc is a ligamentous, and a greater arc is when there's little fractures here and there. And one of the ones you would see more commonly would be for a greater arc would be a little chip off of the radial styloid. That would be more common. Another more common presentation would be just a transscaphoid perilunate. Those are probably two of the ones that I would see the most. I actually think that the transscaphoid perilunate dislocations do better clinically, at least in my experience, as opposed to the lesser arc injuries. And I think that's because if you get a good reduction and you put a nice big screw and you get good compression of the scaphoid, that's really all you have to do for those. And so it's a tougher reduction as compared to a typical scaphoid. But I think if you have a transscaphoid and you get a nice reduction, those patients actually can do quite well. But if you have a greater arc injury and there's a number of fractures, to include the radial styloid, or sometimes even the lunate can be fractured in the coronal plane, or these other associated fractures. The ulnar styloid often is fractured as well. Sometimes I end up treating those with a bridge plate because I really think soft tissue rest is really important, and it's hard to piece put every little piece back together. So sometimes a bridge plate can treat those nicely, but definitely very high energy injuries.
Yeah, perfectly. A great summary against those. Lesser arc injuries, just ligamentous injuries. Greater arc when you kind of have a fracture, and when you talk about transscaphoid perilunate fracture dislocation, is when you have this fracture dislocation, but also have a fracture of the scaphoid. And you mentioned it earlier. You mentioned carpal tunnel syndrome, acute carpal tunnel syndrome occurring almost up to in about 25%, I believe you said, of cases where you have a perilunate dislocation. But what else do we want? Say, we have a resident going in, they were consulted that there was a distal radius fracture, but you actually peeked at the films and you saw it was a perilunate. And so you're telling them, this is what I want you to make sure you do on your history and physical exam. What should we be looking for, and what should they be doing?
I would get the first thing you should do before you pull or do anything or numb anyone up would be a good neuro exam. And it's hard to ask a patient, do you feel this? That's unfortunately not super specific. And patients will give you all kinds of varied answers. And so you really want to try to do a very good neuro exam. The best thing you can do is just take a paper clip and bend it around a bit. And you can ask the patient if they feel 2 or 1, and that can just take a few seconds really. And every ER has a paper clip, but that's probably what I would do for a little bit more specific of an exam for static 2-point discrimination. But these need to be reduced. I sometimes have residents, sometimes don't. If I do have residents, the residents usually take care of this for me. If I'm on my own, I usually ask the ER doctor to reduce this. But on exam, they'll have, you should do a neuro exam first. They're going to have a pain and swelling, and you want to make sure you have scrutinized x-rays of the wrist and elbow. And a good percentage of these are polytrauma, especially where we are. There's a border wall, if people fall off the wall. So a kind of a good general orthopedic exam is important, but I would focus on the neuro exam. And then these need to be reduced. And typically the means, especially for a junior resident, finger traps are about the best thing you can have on hand. You would move the patient to the edge of the gurney. So if it's a right perilunate, you would move the patient all the way to the right side of the gurney, so the elbows flex to 90 degrees. The index and middle are in finger traps. And then I don't know what you guys are using now. I used to hang lead vests off the patient's biceps, or you can sometimes get a stockinette and get some weights and use that. But you put a little bit of weight there, and then at that point you can, or shortly there before, you can numb the patient up. And usually you can get these reduced with just a hematoma block. Sometimes they require sedation. But from my perspective, when I'm on my own taking call without residents, I have the ER doctor try, and if he's unable to, and they're usually 50-50, the more acute the injury, the higher the likelihood, I think, that the ER doctor is able to reduce these. But if he's able to reduce them, I will see the patient at clinic typically, or sometimes just get the patient admitted and do it the next day or something like that. If the ER doctor cannot get them reduced, I take them to the OR. I don't myself go to the ER and then go to the OR. I just will try in the OR, and if I can't reduce it, I just make the incision and just take care of it. But I always try to do the either through the ER doctor or the resident, try to get that reduced in the ER.
Yeah, and as far as your reduction technique, you mentioned, bring them to the side, finger traps, hanging weight on, and I think I've reduced maybe 2 of these, and it's being kind of the same, like exaggerating deformity, putting some traction, and then putting it in some type of mobilized sugar tong splint or some type of immobilization. One thing I wanted to quickly touch base on was the X-rays and evaluating the X-rays. And if I wanted to take a quick second, if you could explain kind of how you go through evaluating these, because I know sometimes these injuries can be easily missed. Like if there's any systematic way that you view wrist X-rays or any lines or anything that you pay attention to.
Yeah. And then the other thing, one more thing about the reduction, usually, so exactly as you say, you can exaggerate the deformity, so it's extension. And if you put your thumbs on the lunate, or thumb, I guess if you're by yourself, if you put your thumb on the lunate and try to shift that dorsally as you extend the wrist and apply traction, usually can pop the capitate back onto the lunate. But in terms of the X-rays, yeah, I mean, these are missed 25% of the time. In fact, I have one tomorrow that was missed for 3 weeks, and sometimes the radiologist misses it. Sometimes the emergency medicine doctor thinks there's a fracture or wrist sprain or something like that. But these are missed 25% of the time. It's just a difficult thing. I don't know that it's necessarily anyone's fault or whatever. It's just these are difficult injuries, and can be quite subtle. But I think if you scrutinize your x-rays, your likelihood as an orthopedic surgeon of missing would be considerably lower. I think the easiest thing to do is Galula's arcs, and that's just kind of a rule of thumb. You can see the relationship or the joint between the proximal row, so the scaphoid and the lunate, and the distal radius, and then similarly you could look at the arc between the midcarpal joints, so that would be the capitate and scaphoid, and the capitate and the lunate, and you should be able to kind of trace your finger across there, and it should look like a joint. So that's the easiest way to do it. I think another way to do it, staying on the AP, would be the carpal height ratio. So that's something I always do. If I think there's kind of looks funny and I don't really know what's going on there, I'll measure the height of the third metacarpal versus the height of the carpus, and the height of the carpus should be 50% of that of the third metacarpal. So if it's not, and the carpus is significantly shorter, that capitate's sitting in the lunate fossa, and this is just on an AP, and so you know the carpal height is not what it should be, and so that is a pretty easy thing to do. And that can be done as a backup. You can put that in your note to kind of support your diagnosis if you're saying there's no instability of the carpus. But also on the AP, they say the lunate looks like a pie in the sky or a piece of cheese. Galula's arcs will be abnormal. The carpus will be shortened, and the lunate it doesn't look right. It looks like a kind of a triangle or a wedge of cheese. On the lateral, you can see the lunate. Yeah, I think your mouse is on it there. The lunate is palmar typically to the remainder of the carpus. It can be flexed, and again, it's flexed because of the short radial lunate. But I think that the best thing to get you out of trouble, the easiest thing, is Galula's arcs. If you want something a little bit more objective, I would measure the carpal height ratio, and you can always put that in your note as something that's a little bit more objective.
Yeah, I like that, the carpal height ratio. I have not measured that before, but now I'll definitely take a look at that and look that up after here. And definitely for those that are listening, you did a great job summarizing and talking about what to look for on the imaging, Galula's arcs, and making sure everything looks right. Now, you mentioned, we kind of went over the acute management, but say, for example, you take them up to the OR, and that you try to reduce it, you can't get them. What does the surgical management look like for this? I guess I'm in two parts. I guess one is surgical wise, what are your techniques, or what are you doing? And then the other part to it is, what is the chronicity? So say, for example, can you wait a week or 2 weeks before you do the same thing, or does your management change? So can you kind of take us through some of these different?
Yeah. So if I'm by myself and the ER doctor cannot get this reduced, the patient needs to go to the OR, and these always seem to come in the middle of the night. So if this came in at midnight and you had a first start the next day, you probably could put it on as first case. If you didn't and you were at a different hospital, you would probably need to get it done that night. I wouldn't let this go 24 hours with being dislocated, but that's kind of how I would treat that. If I take the patient to the operating room for a reduction, that patient's going to get surgery. I'm not going to take the patient to the OR for a reduction and then bring them back to the OR at a later date for the surgery. I'm going to be there. The surgery does not take long at all. Maybe 30 minutes or so. So I'm going to just do this at the time that I reduce it. And so I do try to reduce it. I think it makes the surgery a little bit easier to have a reduction, but I don't know, maybe I'm 50-50. I don't know, but I'm going to make an incision if I take a patient to the operating room for this. So I make a dorsal incision, kind of as you have shown here, which is vertical. I feel Lister's tubercle. I go just ulnar to Lister's tubercle, and I extend it a few centimeters or so that I could get to the capitate. I always surgically transpose the extensor pollicis longus. I end up putting it back to try to restore the anatomy, because in residency we never put the EPL back under Lister's tubercle, and I was told that doesn't matter. But patients complain of their thumb being weak, so I actually do think it matters. So I do put EPL back always. I didn't until I had so many complaints. I thought, oh boy, I better put the EPL back going forward. And I have not had another complaint about thumb weakness. And then I elevate the second radially, and I elevate the fourth ulnarly. At this point, you're staring at the posterior osseous nerve. You can take it. there's some literature that suggests it matters. I don't know. I don't know that it does, but it's right there. So you could take it if you wanted it. And then I make a dorsal a capsulotomy with a distal flap. And so one of the things about the flap is if you haven't done these, you could just go make a T. That's kind of what you would do for a scaphoid. But I think making a distally based flap, I think it allows you to advance the capsule a little bit, and that tightens these guys up. And so I kind of like to do that. But one of the tips about making this capsular flap is you want to make sure that you're carrying it radially and ulnarly enough to see what you need to see, especially when you make an incision and it's into the capsule and everything's dislocated. It's going to look kind of confusing in there. Bones are going to be here, they're everywhere. You're going to think you're seeing the lunate, and it's really the capitate. So I would make sure you make that capsular flap wide enough. And I think anyone who's listening to this who does hand surgery would be able to attest, especially when you're doing like a 3LT reconstruction, which is more of a chronic surgery for a scapholunate ligament injury. Making these wider flaps, I think is critical. So I just do it the same way every time. So a perilunate distally based flap that's pretty aggressive radially and ulnarly, and I fold that up. And at this point, you should be able to get the reduction. You usually are going to have to use a lavage or something that'll help you be able to see, but it really looks like a bomb went off in there. But with a little bit of traction, you can usually milk the lunate back under the capitate. But fluoroscopy is important. If you don't know where you are, that's really not unheard of, because everything looks discombobulated. You can take a 4 or 5 K wire and put it in a bone and take an X-ray and see what you have. But at this point, the reduction is not very difficult. And if there's interposed soft tissue, you could certainly remove that at this time, and that makes it easier. And then in terms of next steps for fixation, you get everything lined up. I usually use 3 K wires. The two most important ones in my view are the SL pin, the followed by the SC pin. Although my sequence is usually scapholunate, lunoid, and then lunotriquetral, and then scapholunate. Scaphocapitate. And the scaphocapitate pin may seem redundant, but it really, I think it keeps the scaphoid from flexing, so it takes tension off of the SL repair. So I like putting the SC pin in, and it's really not hard to do. You do have to aim more dorsally than you think, but I think the scaphocapitate pin is important. In terms of the reduction, I think there's a couple ways to do it. If you're by yourself, I have found that just putting your thumb on the capitolunate joint gives me the best restoration of native anatomy. So I usually start the scapholunate pin under fluoroscopy to make sure I have the trajectory. I get it about 90% of the way across the scaphoid, and then I put my thumb on the lunate, and that seems to restore Galula's arcs the best. But a couple of tips could include using point-to-point clamps. So I'd ask for the regular bone forceps, but also the bigger ones too. And then you can also use joysticks. So for the lunate, you're trying to get the lunate back into flexion. It's extended. So you would drop your hand towards the radius, put a 4 or 5 K wire in the lunate, and then as you move that distally, that'll bring the lunate into flexion. Some people pin the lunate through the distal radius. So as you're driving the scapholunate pin across, you're pushing the scaphoid into the lunate. The lunate's fixed to the radius. That's another way of closing down that scapholunate gap. And then you can also put a joystick in the scaphoid and the lunate, and then wrap them around each other, or hold them with a hemostat, something like that, and that can reduce your SL gap. The SL gap is really what you got to be focused on. I would worry less about the LT. I think putting an LT pin is mostly supportive of the lunate. I don't think you're necessarily treating the LT joint itself, but it's keeping the lunate in a reasonable position. So those would be my tips for getting your reduction. Once it's reduced, I usually clip pins under the skin. You can leave them outside the skin, but I actually had an infection. I had a patient get septic arthritis once. He was immobilized for a long period of time. So I like to keep them under the skin. I think I can keep them in a little bit longer that way. And then I use a micro suture anchor. So there's different companies, but I use metallic anchors for this, because I think the all suture anchors, just the mechanism of an all suture anchor, you got to drill a little bit deeper. And I don't know that you always have that ability in hand surgery. So I generally prefer metallic anchors. So I use a microsuture anchor, typically in the lunate, sometimes the scaphoid, and I just repair the SL. I keep the sutures long because at the end of the case, I advance that capsule back down dorsally, and I try to secure the capsule to the suture anchor as well. And then you can either use transosseous tunnels, or more often than not, just sewing that dorsal capsule to the periosteum of the distal radius is sufficient. But I don't typically use like headless compression screws. I know that was kind of in vogue when I was in fellowship, and I really have not seen them much, and so maybe that's fallen out of favor. But that would be like a Rassel screw. I think they're kind of a pain in the butt to get out, and I think they're really non-physiologic. So I would rather do the repair, pin it, and just watch them in clinic, as that may diastase a little bit once the pins are pulled. The SL gap, that happens quite a bit. I'd rather see that than see a non-physiologic headless compression screw compress the heck out of the SL joint. It's hard. These things are hard to get out. Patients don't like them, and then I hate doing surgeries where there's not a good plan B, and the plan B is you got to go on and try to get that thing out. It's a nightmare. So I don't like doing the screws. I guess I do it the old-fashioned way.
Yeah, with the pins. No, that was a great that was a great explanation of the procedure. You go dorsally, you make your incision, you raise your flap, you try to locate whatever you can. If you need some help, you can put a pin in a bone and get a X-ray and see where that is. But after that, you reduce it. You can hold it with your thumb. You said you pin your SL joint or your scapholunate joint. You could put some pins in the lunotriquetral joint, but I think you said that kind of helps stabilize more the lunate. And then you also put something across the capitate as well. And then you like to use the metallic anchors to do your ligament repair. And so what I guess what would you do if this is 3 months out? Does that change anything at all? Like if this is a chronic missed injury and it's being dislocated for 3 months, and like a young construction worker or somebody like that, does that change any of your technique or what you may do?
Yeah, I think the test question you might be driving at is should you just do a PRC? I think getting it reduced at 3 months is going to be difficult, but I'll tell you, just one of the principles in my practice, this goes for amputations as well. I always try to do the salvage. I never try to start with a salvage procedure because it doesn't set you up for a good plan B. And I never want to be accused by a patient of not being considerate and, Dr. Dunn really rushed this or whatever. So I always try to, if there's an amputation, I try to salvage the finger or whatever. I try not to go straight to an amputation. Same thing for for the lunate and a PRC in a perilunate, even if it's been out weeks or even months potentially. And I have had these cases. I at least thus far have always been able to reduce them and fix this. Now I have had a patient go on to lunate avascular necrosis, but she was stiff but not incredibly painful. And so I don't know that she would have been much better than a PRC anyway. And I can always go back to a PRC as a plan B if she wants it. So I think the test question, a young laborer, someone who says, well, I'm moving to a really rural part of the country and I'm going to work on an oil rig and I can't have this pinned and I don't want pins in, just do one surgery for me. Then yes, the answer is a PRC. I live in a part of the country that has a lot of oil rigs, and I'll tell you, most people still want me to try, and that is my preference as well. I never want a patient to regret or think that I didn't try to save it. So although it's AVN of the lunate's a real thing, it's a very sensitive bone. I always give it a shot. The other thing I wanted to mention, if you have a complex greater arc injury, a tool that can be very helpful to you it would be a bridge plate. And so I would not do these on a lesser arc injury, but a very comminuted greater arc injury that you want the patient to kind of sock in and you want soft tissue rest for a prolonged period of time. I think a bridge plate is a great option. There's a bunch of companies that make them. Synthes has I think it's a 2.4, 2.7, but the problem with that plate, as I recall, there's no glide hole. And so kind of the nice thing to do is to fix it in the metacarpal and then swing it over to the shaft on the radius. It's usually between the first and second dorsal compartments. And if you do have a glide hole, you can just put the screw concentrically and then give a little traction, not too much because you can distract the carpus quite easily, but a little bit, and then tighten the proximal screw, and that gives you a hair of distraction, and supports the carpus quite nicely. And I usually just do 2 screws distally, 2 screws proximally. But again, I think the Synthes plate may not have a glide hole. I usually end up using TriMed because I use them for wrist fractures primarily, but they have a bridge plate with a glide hole, and I know some of the other companies do as well. And then the other thing I do is I do a carpal tunnel release on basically everyone. The worst thing to do if you do a good job in the surgery and you're on your way home and the PACU nurse says, oh, the patient can't feel his fingers or something, and whether that happened from the surgery or from the injury, which of course is the most likely thing, you don't want to have to drive back in and get the guy back for a carpal tunnel. So I just release everyone's carpal tunnel. It adds 5 minutes to the surgery. Patients probably need it, and I just think it's probably the safest route, just to routinely release the carpal tunnel as well.
And for the dorsal bridge plate, do you go to the second or the third metacarpal? I know that's always a discussion.
Yeah, you're right. It is a big point of discussion. So I always go to the third no matter what. So people go to the second, say, well, it restores a little bit more radial height because you're only deviating the wrist. And the other argument is that it saves the third metacarpal should you ever need a fusion. So I've never done a bridge plate like for a distal radius fracture or whatever, and later converted it to a fusion and say, oh shoot, I should have done the second because now I really need that bone for the fusion. So I literally have never had that happen. I think it's theoretical, and I think putting it in the third aligns. The third metacarpal should align to the capitate, to the lunate, to the radius, and so that's the intermediate column of the wrist. And so I think putting the bridge plate onto the third metacarpal makes the most sense physiologically, and I really don't think there's any downsides. And I think I don't think there's any benefit putting into the second. I just have never needed that in my practice, and I think the third restores the native anatomy the best.
Okay, perfect. And Dr. Dunn, one other thing I wanted to quickly touch base on before we wrap up here is, what is your typical post-op protocol? Say, we had one of these, we fixed it acutely, we put a couple wires in, you repaired the ligaments. What do you do post-operatively?
Well, so 2 weeks in a splint, and just a short arm splint. And then the patients come back, pins are under the skin, they're in a cast for 4 weeks. So that's a total of 6 weeks of mobilization. I cut them out of the cast. I usually only take x-rays at the 6-week point. That's the same for distal radiuses. I don't get x-rays at every visit. So the second post-op visit at 6 weeks, I cut them out of the cast, take x-rays, and then I give them a removable brace, and I schedule them around 8 weeks for pin removal. So at even post-op day 1, or when I see them in clinic at week 2, I tell them that I really want them to work on finger flexion, finger motion, and supination. Obviously, they can't do wrist flexion or extension. They're in a splint and then a cast. But I don't want them to wait 6 weeks to start finger motion. So they don't need formal therapy, but I do want them working as much as they can on finger motion and wrist supination, forearm supination. At the 6-week point, they technically can move the radiocarpal joint. They're oftentimes too stiff, but what I don't want to do is have them show up to the surgery center at week 8 with their cast on or anything like that. So I usually do put them in a removable brace at that point. It's a little bit easier for them to get around and to do hygiene and stuff. And then those pins come out usually at the surgery center at about 8 weeks. And at that point, we're starting therapy. It's really for range of motion. I like doing a push-up progression because I think it really helps with wrist extension. And most patients don't get back to doing push-ups. So active duty patients, 2 years after this injury in our study, only 50% remained on active duty. And a lot of those guys were not doing their push-ups with their wrists extended. They were doing them with their fists. So I think patients always have problems with wrist extension, grip strength. It's a debilitating injury, but I think doing a push-up progression mostly for stretching, probably for the first month on the wall, is the best way to get back wrist extension. Then you can dial up a little bit of pressure as you do wall push-ups. And so I think that's a big part of the post-operative protocol.
Well, that's been great. Again, Dr. Dunn, I've learned a lot from just this podcast, is talking to you about perilunate injuries. Anything else about perilunate injuries that you want the listeners or anybody else to know about before we wrap up here?
No, I don't think so. But listeners can reach me at my website, which is johndunnmd.com, and I'm on Twitter at johndunnmd.
That's perfect. That's exactly what I was gonna ask you next. You beat me to it. Well, Dr. Dunn, again, it's been great having you on as a podcast guest. Those that are listening, thank you all for listening. I hope that you enjoyed this episode. Please go and leave a rating and leave a review. Let us know how much you enjoyed it, and we will see everybody next time.
Okay, thanks, man.